In this presentation, we will be discussing adult and pediatric obesity. My name is Dr. Lynn Shea, and I am a family nurse practitioner in a rural health center in Pennsylvania. I have practiced for the past 10 years serving rural farming families with a wide scope of practice including care of children, women's health, chronic disease care, acute care, and procedures. I became interested in the field of obesity while working with the current medical director for the Weight Management Center in her health network. Obesity is a growing and pervasive illness among Americans today. Approximately 35% of Americans are considered obese, and this number is expected to increase. The most alarming trend is that of children and the rate of obesity, which is now approximately 17% and increasing. Obesity affects each body system and has long-term as well as short-term sequelae. Obesity is often thought of as a disease in which patients have made poor food choices and have neglected to remain active. However, new and ongoing research indicates a genetic predisposition, and in some individuals, that affects hunger and satiety signals conveyed through the nervous system, insulin secretion, energy metabolism, and lipid usage and adipogenesis. The risks from obesity include diabetes, cardiovascular disease, AFib, hypertension, non-STEMI, varicosities, cancer, skin infections, arthritis, gallbladder disease, GERD, acute pancreatitis, non-alcoholic fatty liver disease, stress incontinence, infertility, and obstructive sleep apnea. Etiology of obesity comes from calorie excess, either overeating or high intake of carbohydrates, food insecurity, where eating from a fear of potential hunger or past experience with poor availability of food on a regular basis, genetic predisposition with familial history, influences of ghrelin and leptin levels, medication influences such as antidepressants, anti-seizure, steroids, insulin, and oral contraceptives. Psychological factors, food is self-soothing, large carbohydrate intake, which increases serotonin levels. Disease states such as hypothyroidism, insulin resistance, polycystic ovarian system, and Cushing's. Primary prevention of obesity is a triad: identify, food, and activity. Identify those at risk, both adults and children. Calculate BMI at every preventative visit. Adults minimum yearly and children at each preventive visit following routine schedule. Provide targeted nutritional advice. Low carbohydrate diets with high protein, small frequent meals throughout the day. Eliminate sweetened liquid calories, including juice. Recommend 60 minutes of activity on most days of the week for adults and children. Encourage good nutrition and activity at the family level, not just the individual level. 24-hour diet recall and use motivational interviewing techniques. Promote good sleep hygiene. Adult obesity. Let's first define obesity. Obesity is determined by BMI, body mass index. Body mass index, or BMI, is an adult weight in kilograms divided by the square of height in meters. Underweight BMI is less than 18.5. Normal BMI is between 18.5 and 24.99. Overweight BMI is 25 to 29.99. Obese BMI is 30 to 39.99. And morbidly obese patients are 40 or over. Obesity is frequently subdivided into categories. Class 1 is a BMI of 30 to 35, Class 2 is BMI 36 to 40, and Class 3 is a BMI of 41 or higher. Class 3 obesity is sometimes categorized as extreme or severe obesity. In children and adolescents over the age of 2, the BMI is determined according to age and gender at birth, using a percentile rather than raw BMI scoring. BMI charts, standardized by the CDC, are used when caring for children. Pediatric body composition varies as children age and is different between males and females. If BMI is under 5%, it falls in the underweight range. If BMI is between 5 and 85%, it falls into the normal range. If BMI is between 85% and under 95%, it falls in the overweight range. If BMI is 95% or over, it falls in the obesity range. In children under the age of 2, obesity is determined by weight for length over the 97.7% on the WHO BMI charts. Differential diagnoses of obesity include hypothyroidism, Cushing's syndrome, PCOS, mesomorphism such as bodybuilders and wrestlers, insulinoma, and genetic diseases such as Prader-Willi. History and physical. The inability to lose weight or gain weight easily, family history of obesity, personal history of childhood overweight or obesity, and non-breastfed as an infant. Abnormal BMI measurement, waist-hip circumference, which has to do with visceral fat, neck circumference, which is a risk of obstructive sleep apnea, and skin findings, candidal rashes, hirsutism, acanthosis nigricans, skin tags, striae, and pressure ulcers. Respiratory, decreased breath sounds. Cardiac, murmur. Abdominal, right upper quadrant pain, Murphy's sign, liver tender to palpation, lipodystrophic fat distribution. Musculoskeletal, osteoarthritis. Psychological, depression. Use the PHQ-9 tool to identify this. Treatment options for obesity include diet, exercise, behavior modification, pharmacologic treatment, and bariatric surgery, and the treatment decision is based on BMI. So, for example, a person with a BMI of 27 with no comorbidity would not be a candidate for medication therapy. With a BMI greater than 25, diet, exercise, and behavior modification is given. BMI over 27 with a comorbidity or over 30 with or without a comorbidity, medication can be added. A BMI of greater than 35 with a comorbidity or BMI greater than 40 with or without a comorbidity, surgery is an adjunct. Comorbidity is defined as hypertension, dyslipidemia, diabetes, or obstructive sleep apnea. A structured weight loss diet is most effective. Encourage formal programs or weight loss groups, such as Weight Watchers, etc. Fad diets should be avoided as there is no quick fix. Promoting a lifestyle change in eating habits is the key. Diet goals should include a program with 1,200 to 1,500 calories per day for women and 1,500 to 1,800 calories per day for men, or a 500 to 750 calorie deficit per day. Low carbohydrate diets, increased fiber and decreased saturated fats, and less than 800 calories per day in certain circumstances under medical supervision. There are a few classes of medications that work differently to promote weight loss. Stimulant medications can decrease appetite, but also may have cardiovascular effects. Therefore, medication is not recommended in patients with coexisting cardiovascular diseases such as hypertension, coronary artery disease, and so on. Other medications can prevent the absorption of fats in the gut or reduce sugar absorption as well. Please see the following tables that illustrate the mechanism of action of each class of drug and potential side effects. The recommended length of treatment is a 3-month trial. If the patient loses greater than 5% of body weight, this is considered a success, and the patient can continue the medication. If this has not been achieved, then the medication should be discontinued. Medication should not be initiated unless the clinician is familiar and comfortable with these medications. See Table 4 of the pharmacology article in this week's readings. Bariatric surgery has proven to promote greater weight loss than any other weight loss intervention. It is also highly effective for the resolution of comorbidities, especially type 2 diabetes. Prior to bariatric surgery, the patient must pass screening blood tests and psychological evaluation. Most centers also require patients to have had comprehensive dietary counseling and proof of failure on at least 2 diet plans. Bariatric surgery. There are multiple types of bariatric surgery, including the lap band, vertical sleeve gastrectomy, Roux-en-Y gastric bypass, and the duodenal switch, to name a few. Most of these are restrictive, malabsorptive, or a combination of both. Post-op patients will need to adhere to a protein-first, low-carbohydrate diet with numerous vitamin supplements for life. Carbonated beverages, NSAIDs, alcohol, and pregnancy should be avoided in the first year post-op. Patients will receive a checkup every 90 days post-op with blood tests to make sure nutritional deficiencies are not developing. Patients with cardiopulmonary issues, psychiatric issues, or substance abuse are not eligible for surgery. Maintenance of normal weight and weight loss is accomplished through a regularly active lifestyle, monitoring weight weekly, and a daily reduced calorie diet. Accountability visits with a health professional, PCP, licensed dietitian, or bariatric nurse also promote maintenance and avoid the increased health risks of yo-yo weight gain and weight loss. Treatment in children. Diet and exercise are the mainstay of treatment. Avoid sugary foods and drinks, no high fructose corn syrup. Avoid fruit juice, eat only fruit in its whole form. Avoid fast food and food high in saturated fat and sodium. Portion control. Exercise 20 minutes at least 5 days. Good sleep patterns. Decrease screen time to less than 1 to 2 hours per day. Approach change as a family. Are there any family stressors? Infant breastfeeding as prevention and a school-based support system. Other options. Treatment options for children not responding to diet and exercise change. Medication is not recommended for children under the age of 16 who are overweight. They can be considered in obese children and should only be prescribed by pediatric specialists. 90-day trials of medication should yield greater than 4% reduction in BMI. If not, medication should be discontinued. Bariatric surgery can be considered in pediatric patients who have achieved near normal adult height and are 10 or 4 or 5. Most bariatric centers of excellence will not perform surgery on patients under the age of 18, but research is continuing in regards to adolescents and bariatric surgery. Screening in children. This should occur at every preventative visit. Labs for children at risk who are overweight or obese include hemoglobin A1C, comprehensive metabolic panel, fasting, and lipids fasting. Screen for obstructive sleep apnea. Does the patient snore, awaken tired, awaken frequently at night? Screen for depression. In adolescent girls with irregular periods, screen for polycystic ovarian syndrome. If extreme obesity occurs under the age of 5, genetic testing is warranted.